Hello and welcome to my channel. I'm Dr. Adil Yousuf and I believe that understanding medical science is the key to unlocking better healthcare for all. Here I aim to inspire and educate by bringing you clear, concise explanations of complex medical topics. Join me as we explore the wonders of the human body and the science that keeps it going. So today we are going to talk about Pheochromocytoma, which is in endocrinology. So what is firstly we'll try to define what is Pheochromocytoma. So look at the definition. A pheochromocytoma is a rare tumor that grows in the adrenal gland or suprarenal gland, causing it to produce too much adrenaline and other hormones. Other hormones are like noradrenaline and dopamine. Specifically, it's a tumor that forms on the adrenal medulla. So you know there is two layers of adrenal gland, outer cortex and inner medulla. So the tumor is present in the adrenal medulla, not the cortex. The inner part of the adrenal gland, which is responsible for producing catecholamines like adrenaline and noradrenaline. Although pheochromocytoma are usually benign, they can have significant effects on the body due to excess production of these hormones. Today we will dive into its pathophysiology, clinical presentation, diagnosis, management, and more. So let's get started. So we move forward and now we'll discuss about the pathophysiology of the pheochromocytoma disease, which is also called 10% tumor and it's 10% bilateral. It is related to the number 10. So let's begin by understanding the pathophysiology, okay, of pheochromocytoma. The adrenal medulla contains chromaffin cells, which produce catecholamines, primarily adrenaline and noradrenaline. Pheochromocytoma, these chromaffin cells proliferate abnormally, forming a tumor. So these chromaffin cells which are present in the adrenal medulla, they start behaving differently. They start differentiating into a tumor. So these chromaffin cells proliferate abnormally, forming a tumor. The tumor then leads to an overproduction of catecholamines, which are released into the bloodstream in large quantities. Okay, so let's discuss 3 points regarding pathophysiology. First one, origin of the tumor. Pheochromocytoma arise from chromaffin cells, as we have already discussed, in the adrenal medulla, which are responsible for producing catecholamines, adrenaline, noradrenaline, and dopamine, as we already discussed it. These tumors cause an abnormal proliferation of these cells, leading to excess catecholamine. Number 2, excess catecholamine production. The primary pathological feature of pheochromocytoma is the overproduction of catecholamines. This excessive secretion leads to the classic symptoms such as hypertension, tachycardia, and headaches and sweating. Due to the increased stimulation of adrenergic receptors throughout the body, you know adrenergic receptors are used in flight or fight mode. So when there's a tumor in your adrenal gland, which is called pheochromocytoma, these adrenergic receptors they don't get suppressed; they get stimulated. Third one, paroxysmal release and systemic effects. Catecholamine release can occur in sudden bursts or paroxysms, often triggered by factors like physical exertion, stress, or certain foods. This episodic release can lead to acute hypertensive crisis, severe headaches, and palpitations, reflecting the profound impact of catecholamines on the cardiovascular system. So, what would be the symptoms? It's a common sense. So, when adrenaline or noradrenaline gets increased, there are effects like symptoms like physical exertion, stress, and certain foods. Okay, let's move on to the another slide. Now we'll discuss about the clinical features. So, clinical features: patient with pheochromocytoma often present with a classic triad of symptoms. You know, many diseases have triads, so this one also has a triad, which we have to understand. First one is headache, second one is sweating, and third one is palpitations. However, these aren't the only symptoms. Hypertension is the hallmark feature, which can be either persistent or occur in sudden severe episodes. These episodes can be triggered by stress, physical exertion, or even certain foods like cheese or wine that contain tyramine. Patients might also experience anxiety, tremors, and unexplained weight loss. The symptoms are often paroxysmal, meaning they come in sudden bursts, making the diagnosis tricky as they can mimic other conditions like anxiety disorders or hyperthyroidism. So we know pheochromocytoma causes anxiety and hyperthyroidism like features, but the mechanism is different as we already discussed. So now we will discuss about the diagnoses. So diagnosing pheochromocytoma involves both biochemical tests and imaging studies. So two things, biochemical tests or and imaging studies. The most reliable biochemical tests are measurement of plasma-free metanephrines. So we'll see the level of metanephrines. We say that this person is having pheochromocytoma. So 24 are urinary fractionated metanephrines and catecholamines and elevated in patients with pheochromocytoma, reflecting the excess catecholamines production by the tumor. So once the biochemical diagnosis is made, imaging studies like CT or MRI are used to locate the tumor within the adrenal gland. Sometimes make scintigraphy or PET scans. Sorry, I'm pronouncing it wrong. Please pardon. Or PET scans are employed, particularly if there is a suspicion of extra-adrenal pheochromocytomas or metastatic diseases. Look at the fourth point. So, in most cases, genetic testing may be warranted, especially if there's a family history of later genetic syndromes such as multiple endocrine neoplasia type 2, MEN2, when Epel-Lindau disease, VHL, or neurofibromatosis type 1. Okay, this was regarding the diagnosis. Now let's discuss about the differentials of this disease. Okay, it is essential to differentiate pheochromocytoma from other causes of secondary hypertension, conditions such as hyperthyroidism, anxiety disorders, or other adrenal tumors. The aldosterone producing adenomas can present with similar symptoms. A thorough clinical evaluation combined with targeted biochemical tests we already discussed help to rule out these other conditions. Okay, let's move on to the another important slide which is regarding the management. So, what is the management of pheochromocytoma? Management of pheochromocytoma requires a multidisciplinary approach. Preoperatively, the patient must be stabilized with medications. The mainstay is alpha blockers, typically with a drug like phenoxybenzamine, to control hypertension and prevent a hypertensive crisis during surgery. After adequate alpha blockers, beta blockers may be used to control tachycardia. So it's easy. It's very easy. You can understand by yourself, and I don't need to explain this. So what is the management? So before the surgery, we give patients alpha blockers, and then we add the beta blockers also. The definitive treatment in surgical removal of tumor, known as adrenectomy. The approach can be either open or laparoscopic, depending on the size and location of the tumor as well as the surgeon's expertise. So the definitive treatment is removing the adrenal gland. So let's move forward. Post-operatively, patients require close monitoring of blood pressure and catecholamines levels to ensure complete tumor removal and to watch for any potential complications. So post-operatively, we need to check the blood pressure, monitor the blood pressure and catecholamines level. Okay, this is the last slide, prognosis. So the prognosis of pheochromocytoma. The prognosis for pheochromocytoma is generally good, especially if the tumor is benign and surgically removed. Most patients experience significant improvement in symptoms and a return to normal blood pressure even after surgery. However, lifelong follow-up is recommended as there is a risk of recurrence or in rare cases metastasis. So this is mainly a benign disease. So there are chances of recurrence. So we need to monitor the patient, his BP and catecholamines like adrenaline or adrenaline level. Okay, this was all for today. Let's see you some other time.